Hello, FloodGate Family. We are here to talk about one of the most impactful changes in happening in healthcare right now, connected care. We've had a lot of questions about this, so we got a couple experts together. I'm happy to announce Dr. John Bernot, who is the Chief Medical Officer of Bravado. And in case you don't know Bravado, they were one of the original originators of the eScript platform, one of the first digital health platforms, and now have been using their technology and AI to help clinicians be able to nudge patients in different verticals like orthopedics to get better outcomes. And I also have with me Tom Layne, who's the Vice President of Sales with Masimo on the East. And really, if you don't know Masimo, they are a market leader in non-operative monitoring solutions, providing healthcare data in the hospital, and most recently, a lot of information outside the hospital that can connect back with their safety net product. So, guys, thank you so much for joining us.
Yeah, thanks, Joe. Glad to be here.
Happy to be here.
Yeah, good. It'll be a great discussion. I mean, this area, reason we're getting so much questions about connected care is because recent survey and prediction shows that 32.3% estimated CAGR growth between 2020 and 2027. So there's a lot of things going on in this space. And one of the questions that I have for you guys, and I'll start with you, Dr. Bernot. I mean, what are you seeing in accelerating this change, this adoption of this remote and digital care modalities?
Yeah, no, I think it's a great question, and sort of the elephant in the room is COVID. COVID has really changed the way we work, and I'll say but that's the catalyst. We weren't able to get where we are just because of COVID. COVID is certainly something that has made the wheels start turning, but really looking a little deeper than that, at least from my perspective, there's a few things that I'd like to point out. Also, one of them is just our movement to value-based care over the last really decade. We're not there. We're not 1 foot in each. We're probably 1 foot in fee-for-service and 1 toe in value-based care. But we're now being required to figure out what happens between visits. It's no longer just what's happening in that visit. And the only way we can know and really focus on the impact there is going to be through being able to connect with these patients, connect with providers, and know what's happening so that we can intercept this. We just can't wait 3 months for our follow-up visit to be able to deal with that. That's the first thing. I think the other thing I was going to mention, though, is just the infrastructure that we've had. It's been about 10 years now that we've had meaningful use go into, and we can talk about that and certainly could beat that up all day if we wanted to. But the infrastructure has been laid, and it is finally maturing to the point where we have something to build on. So we have a bit of incentive on the quality side. We have a little bit better of a platform. So I think that's driving. And then COVID, like I said, has been the catalyst that just said, okay, now we have to use all these things and do it really quickly.
Yeah, that makes sense. I mean, you've got the platform, with that meaningful use set, and now you have value based, so you have to follow the money. In healthcare, a lot of times that's happening, and then COVID only accelerated it, and really the push to interoperability too as well. There's some federal push and some other push, to have interoperability brings these things together, get that data right. So that's interesting. Tom, I'm curious from your perspective. You've seen it from the commercial side. What do you think's accelerating the change?
Yeah, I think to John's point, right? It has been COVID. It's really accelerated things. I just saw a Wall Street Journal article on not only healthcare technologies, but things like food delivery to home. Going from the grocery store to bringing it home. That we all used kind of pizza delivery for a long time, but now that's expanding. And so there was a statement that this technology has really been fast tracked by about 10 years. And I'll tell you, it's one of these things where the pandemic has been so hard for so many people, especially the healthcare workers that are on the front line, right? Having to, deal with what's happening right in front of their faces. And for us at Masimo, we're used on about 200 million patients worldwide every year. And so to take that expertise that we've developed in the hospital with our non-invasive technologies, our sensing technologies, our different platforms, and then help hospitals apply that expertise to the home has been pretty amazing. And in fact, one of the products that we came out with is our Masimo Safety Net that you referenced. It was fast tracked by the FDA in 3 days. I mean, 3 days it got through. So to bring that out and then have an impact on some COVID patients, it was just brought to my attention by one of our managers out there. The app on the Apple Health App Store, it actually has a review on there where someone had talked about using the technology at home. Again, trusting it because it's used in the hospital. It's not kind of a gadgety thing that you might go to Walgreens or Amazon to buy, but someone that's trusted in the hospital for accuracy on a sick patient, and had a phenomenal outcome. So we've really, as hard as it's been very gratifying to support the healthcare workers that are on the front line with technologies that are really making a difference. And it's the stories that are coming in from our team in front of our customers has been very, very inspiring, gratifying, even though this pandemic's been very, very hard for all of us.
Yeah, that's awesome when you can see that direct impact of the product you designed to have that impact on that single patient, right? And how it's impacted them. So that's powerful. You know, a patient outcome is crucial, but Dr. Bernot, you mentioned a little bit. I'd like to go deeper into it. The final financial impact, you know, that value based maybe, but what are the key financial impacts of these changes that you're seeing and predicting?
Yeah, no, I think it's a great question because it's the other side of the coin. We want to do better on the quality. We're held to these, but it's going to ultimately need to be linked to payment if we're going to really, really change the field. That's how this works. No surprise to anybody listening. But there's been a few things that's going on in addition to these bundled payments and value-based payments that we've already seen. There's been some regulation changes recently, and we were told from our friends, the insurance providers, for years as physicians, can't do that. We can't pay you for that. Can't pay you for a phone call. We can't pay you for an e-visit. We can't do this. We can't do this. All of a sudden, COVID came around, and within 2 to 3 weeks, we could do this. We were able to have these visits. So I think we got a little bit of help on the regulation side. CMS and others had been slowly moving towards some CPT codes that lent themselves to remote patient monitoring. So I think the regulations have definitely helped. But then again, it is these bundled payments that you mentioned and we talked about a little bit ago. And I'll tell you, some of our customers in the orthopedic space, there's a lot of the bundled payments around the CJR, that's the joint replacement bundles, as well as private bundles that are going on out there. Well, they have turned the orthopedic surgeons into primary care doctors on both sides of the surgery to some extent, where they have to optimize their patients. If they want a good outcome, they can't just do a great job in the OR. They need to be able to say, I need to make sure this patient is prepared, ready for the surgery, and then after surgery, monitor and connect with them at their home. What's this wound look like? Let's get a picture. Let's get a remote blood pressure. Let's get a remote glucose. Let's get some of these devices in action and make sure that we can communicate with the patient across the spectrum. So I think those two things, just really being able to work with these new regulations that are helpful, they're coming in the right direction. And then the bundles, and then the final thing I'll say about the bundle, especially in orthopedics, let's not minimize how much of a hospital's budget is made on elective procedures too. The hospitals are really suffering because of these high dollar surgeries. And that is something that I think is really something that we should focus on, and why our friends in the orthopedics, the surgeons and the practices are very interested in what we're doing, because they are the lifeblood of some of these institutions. And again, we already said they have to do a good job on the whole bundle from end to end. It can't be just in the OR.
Yeah, that's some great points there. I mean, you really, they're owning that single dollar. How can they maximize that patient? If something goes wrong, it's coming out of that same kitty. It's something that was profitable for a hospital now goes into that negative column as a liability, and that doesn't work for long term. So that's some powerful changes. Guys, I did forget to mention, if you have questions, we're going to take some questions from the gentleman at the end of this little discussion. So just put it in the chat. If you're putting in questions in the chat, we'll take a couple minutes at the end and answer those questions. So if you could do that, it'd be awesome. Tom, curious what you think about what you're seeing as the financial impacts that Dr. Bernot might have mentioned or, didn't hit.
Yeah, so, our phones have been ringing off the hook from our customers. We've got, about, as I said, quite a few patients are using our technology worldwide. Got a large customer base with some of the largest hospitals in the United States. And when you look at the calls that we're getting, from New York City back in March and April of how do we use your technology outside the hospital? What is the financial aspects of it as well? It's all things that you have to take into consideration. And what I can tell you, Joe, is that we actually have hired some billing experts I'm actually getting an echo here. I don't know if that's me or can you still hear me okay?
We got you fine. There's a little bit of modulation, but I don't know how to fix it. We'll continue.
So what we realized is for our customer base, we had to hire people that were experts in this. So we've gotten really, really good at the remote patient monitoring CPT codes, how to help hospitals create a really measurable ROI for these products to manage these patients. Because if you show up and ask a hospital to figure this out on their own, number one, with the pandemic, everyone's stressed. Everyone's trying to figure out where they get PPE. And so when you start looking at some of these technologies and taking to the next level, that's where we're trying to show up and be flexible as possible to either meet them at the beginning stages or some of the larger systems that are maybe more robust. We can actually provide technologies around not only managing patients, but the financial aspect too, to show them how they can manage this and not, make sure that's not going to be a losing proposition for them financially.
Yeah, that's a good point. I mean, you gotta be able to show what that ROI, make it simple, make it easy to understand, and come in as that expert, in that as a consultant, really. That's important. On the other side, go ahead. Sorry.
I was going to say, Joe, because before the pandemic, no hospitals were experts at remote patient monitoring, right? So then the codes came out and we asked them to be experts, but I think so as a company, we realized that we have to help fill that gap to help them become experts so they can manage this financially and clinically. Yeah,
makes total sense. On the other side of the coin, right, you have the hospitals and the clinicians. What I think has been an interesting, I think will even be a bigger driver. I mean, you look there's been a 340% increase of Medicare recipients. So the adoption of telehealth in the elderly and the senior population, which people said would never happen, is happening. And I'm curious of your impact that consumerism. I don't want to go into a doctor's office and have to read an old magazine if I don't have to. So what's the impact of consumerism? And Tom, I know Masimo sees that. I mean, I've seen the Morgan Freeman ads, awesome ads, by the way. So curious how you see that impacting this segment of healthcare.
Yeah, I think it's simple, Joe, right? When we buy something for our homes or for our own person, we expect it to just work, right? Yeah. But if you look at what's been out there for healthcare up to this point, it's kind of been junk, right? You can go on Amazon, like I said, you can go to Walgreens, and for $20, you can buy something that might work and it might not work. So our tagline is at hospital and at home. Every consumer, if they can get something that's been proven millions and millions and millions of times on the sickest patients in the hospital, that it's accurate, that it's reliable, and they can use it to manage their health in a better way, that's what we're bringing to the marketplace. So what we're seeing from the consumer side is, again, these are kind of stories that hospitals are sharing back with us that, folks are getting their readings on their phone, their vital signs through wearable devices. And when they trust those readings, they then come back to the ER sooner, right? And they might come back a day sooner than if they had stayed home. So really, it comes down to, we as consumers expect that the products that we use are simply going to work, plug and play, and that's what we're bringing to healthcare consumerism. And so it's really a nice meeting of both healthcare expecting things to work and consumers expecting things to work.
That's great. And Dr. Bernot, I'm curious from you, you're still a practicing physician part of the time. So I'm curious your perspective, what you might be hearing from your patients and what their reactions might be if you have some insight.
Yeah, well, I totally agree that I think patients have this expectation. And what do you mean I can buy my movie tickets, book my flight, I check in for everything, and then I cannot get to this via the phone? I mean, it's really been striking with the telehealth that we've now all of a sudden turned on. Again, the things that we've said, oh, we can't do that, we can't do that, we can't do that. All of a sudden we're saying, yes, sure, we can do that. So I think the expectations are now set. We cannot pull these back. That would not go very well. But even into the monitoring, I totally agree. We're seeing this on the device side with the wearables. We're seeing it with the telephones, having these things. And I have a lot of patients come in to me and I say, well, what are your blood sugars? And they come in on the phone and they show me their phones. There's no longer the paper logs that are coming there. So there is an expectation from the patients that I will ingest that data. We still have a problem that my system, my EHR, cannot ingest that data. So we need a lot of that interoperability to go, but I think the patients are going in the right direction. I like their expectations. They should demand this. It is demanded in every other aspect of their lives. So I'm very pleased with that. And I also think, getting to some of the patients we've had, again, we're working on these connections to surgeons, and I use that as for example, is reputation matters for elective procedures. And it's not always the only driver. There may be one small surgery office in your town, but over time, there's in many of the big cities, you get to pick, you get to decide where, and these kinds of things are just going to be expected. Take away patient satisfaction, take away outcomes. There's just going to be an expectation that if you're going to deliver as a hospital, as a practice, you're going to have these for the patients. And if they have the options, I think they'll start to look otherwise.
Yeah. I mean, you've seen that trend banking, how quick, once someone did it, how quick it just, it changed the way you did things for centuries. So it's really good. And now we talked about a lot of that tailwinds, right? The consumerism, we talked about the value bundling, the fact that we now have the EHRs, EMRs are now, mature. But what are the tailwinds? What are you seeing that might be holding this back? And the second part of this, Tom, I'll address this. What can they do to help these roadblocks, knock these roadblocks out of the way?
Joe, I was having a conversation with a large health system. This is maybe been two weeks ago, and we were talking about flexibility, right? And this VP of one of the service lines made a comment. He said, it's funny you say flexibility, because I met with a company yesterday that said, we can accomplish everything that you want to, as long as you will change your entire approach to healthcare business to fit what we do, right? So that's some of the problem I think that a lot of hospitals are seeing, is that they're being pitched on technology every single day. I mean, we see it. Like I said, we have such a huge customer base that we're having these conversations. I have a hard stop at the bottom of the hour to talk to another hospital system about this. But we bring such flexibility that we can fit into whatever the hospital needs. And you talk about interoperability. We've been featured at HIMSS over and over. We've got multiple partnerships with all the different EMRs. We're data agnostic. So we've really built a platform that we want to try to help patients where they're at, meaning, to John's point, are they using their phone for a lot of different technology? Are they using maybe something else? But at the end of the day, you have to be as flexible as possible to help the hospitals, whether they're just getting started or whether they've got a phenomenal program in place. You have to have that flexibility to meet them where they're at, not ask them to change how they do business to use your product.
Yeah, that makes total sense. Yeah, I mean, you got to adjust understand you've got to be nimble enough, right, to work within their system and the way they've created it, right? Because by the time you had to unravel it every time, we'll be waiting for another decade, right?
Correct.
So that makes total sense.
Yep.
Yeah. I'm curious if maybe from the provider side or company side, you've got both hats here. So what's your thoughts? What are the roadblocks?
Yeah, I'll give you an idea from both sides. From the solutions, the company side of things, I couldn't agree more. We are seeing this, that if we're going to go into an organization and help implement and connect with the patients, this is not I'm going to do it how Bravado tells me how to do it. I will tell you how I do it, and you will deliver it in this custom plan. And so we've really, really invested in a platform for that to make sure that we're customizing what they already do. Hopefully over time, we'll start having some solutions, but meet them where they are right now, and we'll help to get that customized solution. And I just could not agree more with Tom that is what the expectations are going to be from the healthcare side of things. Flipping to the provider side of things, we need help. We need help on the payment side, and our infrastructure does not support a value-based way of doing things, way of doing business. As I said, we're not 50-50, and we're certainly not 90-10 value-based. So we're trying to support these value-based initiatives, but the vast majority of our dollars still comes in from a fee-for-service. So we need the whole payment system, the healthcare system, to restructure itself so that we are paying for outcomes, and we're doing, whether it's called value-based, risk, at risk, doesn't matter. We're paying for outcomes. If that's where we're going, we need to have a software, the devices that we need to be able to manage patients in an environment like that. And until the payment system catches up and the regulatory policy side of things catches up, then I think it's going to be very difficult. And that's where we see the strains. And that's why we see this inability for us to be able to bend our workflows into doing it the right way. So that's what I think on the provider side is really the big issue. And there's also on the healthcare side, I hate to bring it up being in the field, but it's slow to move. I mean, there is a reluctance to change even if every single tool is sitting out there in front of us. It's sort of the dinosaur of the field, and turning the aircraft carrier is a difficult thing to do. So that also plays a little bit of a role in the whole issue.
Yeah, it is always, it's amazing to me. I mean, your hometown, Pittsburgh, I mean, it's 90% vertically integrated covered lives, right? You know, between the two major health systems there. And they still have a very much fee-for-service mindset. And they're all owned by the insurer. So even in those environments, it takes a lot for that catalyst to really that mind shift to change and behaviors to change to that true value-based. And I agree with you. That's where we'll go. And the data that both of your companies are providing is that key linchpin that makes that be able to happen. So guys, right now I'd love to take some questions. We've got some questions. I've seen them come through. So I've got a bunch of different questions here. So this one's from Allison. Hey, are hospitals exploring new revenue streams with the reduction of higher dollar elective procedures? Sorry, or is COVID tied up all the resources possible? I mean, you know, with those elective procedures gone, are they really exploring other revenue streams and trying to, you know, monetize patients in other ways? I think is what she's asking. Are you seeing that happen?
John, you want to go first?
Sure, I can go first. So not being on the actual hospital administration side and me seeing it from the provider side, I do see there are some exploration, but to Allison's point, COVID has really tied this up. The time when you really need to do the research investment into how to put these extra revenue streams in place, you're all tied up. What I have seen, though, for sure, is the adoption of the telehealth that we can. Certainly, we're doing many more video visits, more phone visits. We have a better system to bring in revenue from some of those. We're then also optimizing our safety around those elective procedures with things like telehealth, again, and connection to make sure that the folks coming in are as safe as can be. But I haven't seen from my seat major changes yet into how we're changing our revenue streams. And I think that gets into the big shift of healthcare. That's probably a long game more than a short game to be able to switch those. But I'd be really interested, Tom, in your perspective.
Yeah, I think it depends on where the hospital is. There are some hospitals that it's kind of business as usual. They're seeing COVID patients, but they are able to look at what are they going to be doing down the road, both clinically and financially. And so we have seen some hospitals that have been looking at how do they do things better, anywhere from blood management to patient workflow, et cetera. So we have had some of those conversations. But the hospitals that are dealing with COVID, it is a fire, right? So they're not looking at the long term, 5 years down the road, and how am I going to build a service line that can generate revenue? They're looking at I got to find some water. I got to put this fire out. And so that's kind of what I was referring to about flexibility, is that we're really blessed in that the platform that we have out there, we can help the customer in a lot of different ways. If they're looking to move forward business as usual or put the COVID fire out, we've got different solutions for them. So it's just been kind of different with each hospital.
Right. And it's impacted, we've seen it, the geographies differently throughout the year, right? I mean, different places have been operating differently. So it's good. Question, this one seems like right up your alley, Dr. Bernot, is the plans for hospitals and other health organizations to integrate AI-related tech to improve ROI and patient outcomes. They were thinking IBM Watson is what Patrick was thinking, but curious what the implementation of AI, where are we?
So I think we're behind in implementation as to where we are with the technology. And what I mean by that, I think IBM Watson, I think a lot of the AI technologies you're seeing in smaller healthcare companies, healthcare IT companies can really do a lot with that information. But I still think what's holding us back is even less the data, and definitely, as I said, I don't believe it's the solutions. is what do we do with it then anyhow, and does it fit into a financial model? In the high dollar areas, I think we're seeing some of this happen. In our big readmissions plans, big attached dollars to those initiatives, we're starting to see people say, who's the one that's going to come up here and get into my hospital a second time? And there's a lot of data being run. But using it in just the general way so far, even with our outpatient diabetics and heart failure patients, I think we don't have the incentives yet to really get that as implemented quickly. And I don't think the adoption is going to be there until we have a little bit more financial incentive. And as we mentioned, changing the whole way we do our jobs.
Yeah, that makes sense. I mean, seeing it at health economic side of it more than you are really at the ground level, right? Kind of change. So, Tom, any perspective on that?
Yeah, I mean, Joe, I would say that we've got probably over a dozen different pilots going right now, whether it's with analytics, predictive analytics, some AI logic on the back end, and every care area is going to be a little different. And I think that there are some hospitals that are looking at, the references to IBM Watson and, kind of this future state of hospitals predicting what's going to happen to patients. What we're seeing is that there are small things, and some small things that data can help to drive better care, better patient movement throughout the system. And so we've got, as I said, over a dozen different pilots that are looking at how to use data better. We're really about putting the technology in the clinicians' hands and having them utilize it and tell us, what is working, what's not working, and then helping to modify it along the way. So it's coming for sure, and I think it'll be here sooner than what we all think.
Yeah, and to create change, it always takes people. So that's a thing close to my heart. So I'm curious, what kind of talent do you guys think is going to be necessary within industry to make this change in healthcare?
I think, Joe, from our perspective, I've seen, I got my start back in the day with Ethicon, and it was the old model of find the doctor, find the surgeon that was the champion, would beat on the desk and get your product in, right? That's all changed. And I think that John alluded to this earlier, is you have to have an ROI, right? Similar to if you were selling to a B2B customer, if you went to Marriott hotels and you said, hey, I can sell you this bed, but you got to pay $2,000 more. Well, is that going to get people to check into the hotel or not, right? And who's going to take on that responsibility? So healthcare is moving toward a vendor says that you could help me accomplish something. Every vendor says that. So you have to be able to prove it. And we've actually come up with some really unique contracting mechanisms to guarantee performance in different partnerships where there are true measurable outcomes, so that the dollars that are spent on that product, whether it's technology or something else, can be measured. And if we as a group, meaning the customer and Masimo, can't achieve that there's financial compensation. And so it ends up being kind of a no-risk guarantee, if you will, to show that the technology will improve your financial aspects, but also clinical too. So again, it gets back to that flexibility that we're blessed that we've got a flexible platform and then flexible financial metrics to get things done with customers as well. Yeah,
you need that kind of person that has not only that clinical intellectual capability, but also that financial intellectual capability, and to be able to combine both of those to tell that outcomes story, both from a patient level and a total financial level, right?
Yeah, but like I said, we can go down to the smallest 25-bed critical access hospital and help them too, right? Because I think sometimes we talk about technology, you think of the big brand name, top 10 hospitals, top 20 hospitals, but to help every patient, you got to be able to be flexible to go down to those small hospitals too. So a bunch of different solutions that are going to fit into, again, where they're at technology speaking or technology wise.
Awesome. Well, guys, hey, we've made it to the half hour. I appreciate everyone that's come in. Dr. Bernot, thank you so much for your time, your insight. Tom, thank you so much for taking the time and sharing what Masimo's doing. Guys, if you have any questions for these gentlemen, we'll link them into this page. There's a lot of questions we didn't get to, so I apologize about that. We'll try to answer as best as we can in our response. And obviously, if we can help you in any way, please let us know. Thank you so much. Have yourself a wonderful day.
Thank you.